Thank you, Gianluca. Good afternoon, everybody. And let me thank Enzo Bonora first for the privilege he gives me time and again to be and join these lively groups of scientists and young group of fellows. It's very exciting and once again allows me to present a few and hopefully stimulating data from the lipid worlds. This is the disclosure slides. Now, talking about lipids, I have to start with a couple of points about the recently published guidelines, just a month and a half ago. We'll then focus on a very reassuring point. The LDL is still there, still the number one, not talking about anything revolutionary today. The room for something else is there. It's also considered by the guidelines, and then how the superb lipid control can fit into a modern precision medicine setting. The guidelines were published a month and a half ago in Paris and presented at the same time at the European Society of Cardiology. And one of the first tables really redesigned the cardiovascular risk in patients with diabetes, really telling us that the old concept of patients with diabetes having a cardiovascular risk equivalent to those with already established cardiovascular disease is a remarkable oversimplification of the issue. In fact, you see patients with diabetes spread over 3 or 4 of the 4 categories of cardiovascular risk. Those that remains at the very high risk are patients with diabetes without heart disease, but with a target organ damage, nephropathy, for example, a long duration of the disease, or at least 3 other major cardiovascular risk factors. But patients with diabetes are also at high risk if the duration of diabetes is smaller or shorter, or they have 1, not 3 additional risk factors, and they do not have target organ damage. They also may be into the moderate risk category if the duration of the disease is much shorter, or the time actually, the age of the patients, for example, type 2 diabetes is less than 50 years, short duration of the disease without any other risk factor. So concept number 1, patients with diabetes are a very complex group of people with different cardiovascular risks. The recommendation for lipid analysis told us once again that we should focus on LDL analysis, both for the screening, diagnosis, and the management of cardiovascular risk patients in terms of dyslipidemia. So this is a very reassuring point. There is some new concept, but basically, once again, the LDL gets the center of the stage. Now, having said that, let's get deeper into the superb lipid control, and we focus our attention on the LDL. When Enzo gave me the title, I said, well, I thought this is a good opportunity to talk about the future of lipid-lowering strategy, except I did not account for the publication of the new guidelines. So the future is really here, because the superb control is now the recommended goal of the LDL levels. So superb must be now and with the therapeutic approaches we have. In fact, as you can notice here, those with type 2 diabetes at very high risk of cardiovascular disease have a goal of less than 55, 1.4 millimoles, so quite lower than the 70 milligrams of the previous set of guidelines. Those at high risk, the goal is 70. The 70 was the goal initially set in 2016 for the very high risk. So the first concept is there is a shift towards lower levels of LDL cholesterol for each class of cardiovascular risk. Now, the other thing is that how do we reach that remarkable levels of LDL cholesterol, particularly in very high and high risk cardiovascular risk patients? Statins, high-intensity statin therapy is the first approach. They suggest to use a statin in combination with ezetimibe if the goal is not achieved, and in secondary prevention, high-risk patients considering PCSK9 inhibitors together with statin and ezetimibe. Now, PCSK9 inhibitors has the same level of evidence as statins. This is the other remarkable point. PCSK9 inhibitors with the same levels of evidence as statins. Now, when the guidelines were published, everybody was quite shocked about these new levels and said, well, there is no way we can reach such low levels. But before we raise our white flag, let me give you a couple of ideas, one coming from the paper and the figure actually published in the guidelines. We have a way, this tells you how you get the clinical benefits when you treat dyslipidemia. So you get the benefits in terms of absolute risk reduction of LDL cholesterol. But when we use high-intensity statin and ezetimibe, we're able to reach a 65% reduction in LDL cholesterol. And I'd like to remind you that all over Europe, both drugs are generics. And in Italy, you can reach 65% LDL cholesterol reduction with a monthly price that goes from 13 to 23 euros a month. And this is the same amount of LDL reduction you get to PCSK9 inhibitor monotherapy. Of course, if you decide to combine PCSK9, you're allowed to, according to the IFA guidelines, you may reach an unbelievable reduction in LDL cholesterol, 85%, but at a much greater cost than just combining ezetimibe and high-intensity statin. Now, if I remember correctly, the median LDL distribution or levels of the diabetic population in Italy is around 130, I guess, milligram per deciliter. So if you take out 65%, I'm not saying you get below 55, but you approach that number quite easily in a very inexpensive way. So how we can reach superb control? Well, we have a combination therapy that are quite effective and allows us to get a greater than 60% reduction in cholesterol. Now, the key point and the key question to answer is the superb LDL control, extreme LDL cholesterol reduction, providing us with further event reduction. And, you know, I think many of you have seen this the Mr. Green kind of play. I'm using today in a different way, but providing you some examples of how we can approach the problem. So once again, we have patients with diabetes, non-heart disease, so very high cardiovascular risk. These are the goals in terms of LDL cholesterol. We treat the patients with the high-intensity statin therapy, and we get 90. What Mr. Green needs is definitely an additional LDL cholesterol reduction. I showed you we can get this extra reduction by adding ezetimibe, or probably these patients will qualify, or in the future, for PCSK9 inhibitors. Not now with the current rules, at least in Italy. Why did they pick 90? Okay, let's focus on LDL and again answer the two questions. There is another question that is very relevant. If we start with LDL cholesterol below 100, do we get a significant benefit by performing this superb LDL cholesterol lowering, or somewhat the benefit decreases? So this is the Improve It trial. The reason why I picked 90 in these guys is that most of these trials start with the baseline cholesterol levels around 90. 90 is one of the points that is good to start with. Patients with a recent acute coronary syndrome treated with simvastatin alone or simvastatin ezetimibe, starting LDL cholesterol 2.4. Now, this is the effect of 7 years of follow-up with ezetimibe, dotted line, or solid, the ezetimibe simvastatin in those without diabetes. Now, as you can see here, the really significant results of the Improve It trial overall were driven by the population with diabetes. That, of course, looking at the lines, has an increased cardiovascular risk to start with, but a remarkable benefit with an absolute risk reduction of 5.5%, 14 relative number needed to treat of 18. 18 is a smaller number than the 4S in the old times, the trial that actually opened up the roads for the statins. If you look at the LDL cholesterol levels from 93 to 50, so it's, according to the current guidelines, a well-treated population of 70 with simvastatin alone. So patients with diabetes seems to be a particularly high response in terms of, or effectiveness in terms of combination therapy. This has been confirmed by a recent meta-analysis that shows that adding ezetimibe in patients with diabetes provide extra benefit as compared to the same approach in patients without diabetes. But we have newer information from the extremely effective PCSK9 inhibitor. This is Fourier, 28,000 people, 4,500 patients with diabetes on the left panel, on the right panel without diabetes. Placebo is high-intensity statin. Evolocumab is high-intensity statin plus the PCSK9 inhibitors. 30 milligrams of LDL cholesterol, a median level of evolocumab plus statin. Placebo is 90. As you can see here, 2.7, the absolute risk reduction, number needed to treat 37, which is much smaller than the effect seen in those without diabetes, of course, because the baseline absolute risk is greater and the absolute risk reduction is greater. So Evolocumab showed that the benefits in terms of superb LDL controls are there for evolocumab. This has been published 2 months ago, and it reflects the results in the diabetic population of the other large trial. It's called Odyssey Outcomes. Selected people close to or closer than Fourier to an acute coronary syndrome, and this refers to 3 groups of people: normoglycemic patients, of course, the overall results. A relative risk reduction are the numbers on the left, absolute risk reduction on the right. And as you can see here, if we go from normal to prediabetes to diabetes, in terms of relative risk reduction goes from 14 to 16%, so no major difference, but because of the higher starting absolute risk of patients with diabetes, the absolute risk reduction is, as in Fourier, greater in patients with diabetes with 2.3% as compared to patients, the overall population, and patients without diabetes. So because of the greater risk, probably a remarkable and superb LDL control in the diabetic population indeed pays off in terms of cardiovascular disease. I think there is a key question that raised a lot of doubts recently. Do we really need, is really important the extra cardiovascular benefits we see in these patients when we start at lower levels of LDL cholesterol, lower levels at levels below 100? This is a relevant question and was addressed by this meta-analysis, where they look at the magnitude of clinical effect for superb, let's say, LDL lowering patients with already low LDL cholesterol levels, particularly LDL cholesterol levels that started with 70 or 1.8 millimole or less. They look at 4 studies, actually 3 studies and a subgroup from a meta-analysis. This is a subgroup of the cholesterol treatment trials collaborator that started with the 70 in terms of LDL cholesterol. This is the IMPROVE-IT trial I just showed you, ezetimibe, simvastatin versus ezetimibe alone, the group of people that started with 1.8 or 70 or less. Fourier, looking at people that had 1.8 millimole to start, PCSK9 inhibitors, and REVEAL, a trial with CETP inhibitors, a drug that raised HDL and lowers LDL and never saw the light in the market for a number of different reasons. But as you can see, all these patients, all these groups started with an LDL cholesterol of 70 or less, and it's very large in terms of subgroup. And as you can see here, in each one of these studies, including the subset of the meta-analysis from the CT collaborators, there was a decrease in the major cardiovascular events per millimole of LDL cholesterol. So even in this group of people, a decrease of 1 millimole or 40 milligrams, about 40 milligrams of LDL cholesterol, led to a 21% decrease in major cardiovascular events, which is exactly the same effect you see per millimole decrease by any other starting point of LDL cholesterol. Could be 150, could be 200. It covers all the single, actually, clinical endpoint. It's definitely significant for myocardial infarction, ischemic stroke, coronary vascularization. Doesn't reach significance for cardiovascular death. But as you can see here, it's on the right side of the graph for all these points. And it doesn't get or doesn't require a great payoff in terms of side effects. As you can see, any serious event is not different: myalgia or myopathy, transaminases elevation, new onset diabetes, no signs. I like to remind you, the use of ezetimibe and the use of PCSK9 inhibitors so far has not been associated with an increase in new onset diabetes, unlike the statins. Cancer, no effects. In each one of the single trials, including the Fourier and the Odyssey Outcomes, where a large number of people, particularly in Fourier, reached levels of LDL cholesterol below 1 millimole, which is below 30 milligram per deciliter, there was no signs, at least so far, or any serious side effects. So the answer is superb LDL control, yes. It further reduces cardiovascular events. It is true, and it works even when we start with patients already treated and a baseline LDL cholesterol of lower than 100, in fact lower than 70, and so far has been considered very safe. So I think the story ends up here. We have a fantastic target, LDL cholesterol. We have a very inexpensive and effective approach, which is statin and ezetimibe. We have a more expensive but equally or more effective approach that can be combined with PCSK9 inhibitors. We end up with the possibility of decreasing cholesterol by 85%. 85%, it's unheard of just a few years ago. On the other hand, if this is the bright side of the moon, there is something hiding behind. and it's hard to find because there is a lot of enthusiasm about LDL cholesterol, but we have to face a reality that comes from the old statin trials I show you, but also from the new data, where the LDL cholesterol goes down to almost nothing. Because one of the questions I used to get from Inso as well in some of the previous workshops was, it's fine, you have this residual risk, we call residual risk of events in patients with diabetes. But what if the LDL are abolished, are down to zero? You may get down to levels of residual risk that are due to other risk factors, but probably not related to lipids anymore. Now, let's see what the statin trials show. Statin trials, these are 6 of the trials, clearly tells us in patients with diabetes that treating patients with statins decrease cardiovascular events. But the problem is, it decreases cardiovascular events to such a point that it remains higher than those within placebo without diabetes. Or, as we look in TNT, these are patients with diabetes on 80 milligram of atorvastatin. These are patients without diabetes on 10 milligram atorvastatin. So in the pre-PCSK9 era, clearly statins were effective, but the bottom line is that patients with diabetes remain at high risk. Now, what I'd like to show you is this slide that I just presented you a couple of minutes ago, and I have a similar slide. For time constraint, I'm not going to show you, but from the Odyssey. And remember the slides and the curves from the Improve It, 50 milligrams at 5 years, 28% of events, 28%, 50 milligrams, simvastatin ezetimibe. These patients on evolocumab and 30 milligrams of LDL cholesterol had more events than those without diabetes on high-intensity statin therapy and 90 milligrams of cholesterol. So the message we got from these trials is that patients with diabetes, despite wiping out cholesterol, particularly LDL cholesterol, remains at a greater cardiovascular risk than those without diabetes at a much higher LDL cholesterol levels. And the patients in Fourier were recruited as patients at a very high risk with established cardiovascular disease, cerebrovascular disease, peripheral artery disease, but not close to the events, the recruitment. The average time between recruitment and events were 3 years. So we have the evidence that everything is true. The superb LDL control pays off. It is safe. It pays off even when the LDL starts very low. But at the end of the day, we have a problem with these patients. Now, of course, glucose control, blood pressure, there are many, as you see at the end when we talk about precision medicine, issues about patients with diabetes. But as Enzo said, and this is another slide I use quite often, there are other 2 lipids. And let me tell you, there is one class of lipids that really is the culprit probably of some of that residual risk. If you look at the literature in the past 7 years, 65% of the major trials related to lipids and lipid-related approaches have to do with triglyceride-rich lipoproteins and the remnants, not LDL cholesterol. Of the 4 major trials that will be published within the next 3 years, 3 has to do with triglyceride-lowering approach, 1 with a revolutionary new LDL-lowering approach. So clearly, the interest has been shifting towards what's left when we abolish LDL cholesterol. I just summarize some of the results with this study. This, I think, is going to be a landmark study. Once again, is Mendelian randomization done in a very smart way. Brian Ference and his co-worker took 500,000 people looking for very common genetic polymorphisms affecting the 2 pathways. The first pathway was LPL, so these polymorphisms were affecting triglyceride levels. Particularly, they were associated with lower triglyceride levels, lifetime lower triglyceride. No effect whatsoever on LDL. And so the people carrying the polymorphisms was compared to a normal population. These were the measurements. Then another group of people, overall it's more than 500,000, with a common polymorphism affecting the LDL receptor gene, effect on LDL, no effect on triglycerides. So very nice double population for this kind of study. And again, the carrier of the allele affecting the LDL, lower LDL, was compared to a normal population of wild-type genes. So the problem in this paper was, how do we compare pears and apples? How do we compare triglyceride with cholesterol? Well, the idea is that each one of these lipoproteins, whether they're carrying triglyceride or cholesterol, have one ApoB. So the idea was not comparing cholesterol with triglyceride, but comparing ApoB, which means comparing the number of particles affected by these common polymorphisms, and of course normalizing for the same amount of particles. So the idea was to look what happens to cardiovascular risk in patients that have a lifetime decrease by, let's say, 100 triglyceride-rich lipoproteins per millimoles, per milliliters, let's say, in the blood, as compared to those who have 100 lower LDL particles per milliliter of blood, and see the cardiovascular risk down in the life. And as you can see here, they came up with an LDL score. This is 10 milligrams in each one of these two groups. These, of course, affect triglyceride, no effect on LDL. This affects LDL, no effect on triglyceride. And they normalized these two groups by a decrease of 10 milligrams of ApoB. And they came up with the same results. 10 milligrams lifetime decrease in the triglyceride-rich lipoproteins leads to a decrease in cardiovascular risk by 23%. 10 milligrams of ApoB, the same amount of decrease in lipoproteins, but in the LDL, the same number decrease lifetime, leads exactly to the same risk. This is a real proof that 1 equals 1 in terms of heterogeneity. The heterogeneity of one triglyceride-rich lipoprotein equals the heterogeneity of one LDL. Having said that, one number I showed you in the previous presentations that we have a simple number that takes care of all these lipoproteins. It's called non-HDL cholesterol, and it's very simple to calculate. And what I'd like to show you in the next slide is an update from the guidelines. But actually, as you can see, graphically speaking, accounts for all the atherogenic lipoprotein, and the number that represents the goal for this target are very easy to remember. You add the 30 milligrams to the LDL goal. For example, for the very high-risk type 2 diabetic population who has a 55 milligram per deciliter or 1.4 millimole target, the 85 would be the non-HDL goal. Easy to calculate, does not require fasting. And it's something old, actually, because look at NICE. NICE, the UK guidelines have been famous for being very, I would say, evidence-based oriented. Very tightly evidence-based oriented. In 2014, the NICE, and in the following versions again, said that due to its greater prediction, non-HDL should be the primary target of therapy rather than LDL. This is an NLA, and you can come down American College of Cardiology, the College of the American Association of Clinical Endocrinology, and the latest guidelines. So let's take a second guy. The second guy has a more common problem we see in patients with diabetes, slightly elevation in triglycerides, and again, an LDL, which is basically not far from the median we see in our diabetic patients. Now, this time, the LDL approach works. Not perfectly, but decently. Unfortunately, triglycerides are still high. Now, we know that if we use the same approach, we get some benefits. Of course we do. It starts from an LDL below 100. So applying the same concept using ezetimibe or maybe PCSK9 inhibitors in the future, if that is allowed by the rules, actually, will decrease the risk significantly by 14 to 18%. But let's use the other approach if we do believe that triglyceride-rich lipoproteins are affected. And this is where the new piece of information was published in early December last year. The option to decrease triglycerides are not related to ezetimibe, statins, or PCSK9. They have a very little effect on triglycerides, but there are two classes of drugs. I've been used to talk about fibrates. I'm not talking about fibrates today because there is a new study with the omega-3 that really helps us clarifying the point. So when we have this problem with an increased triglyceride-rich lipoproteins, we can use a fibrate in combination of the omega-3. And I'd like to provide the evidence of this trial. This is called Reduce It. In January, usually, the editor-in-chief of the New England Journal of Medicine published a commentary where he identified the 5 most relevant trials published during the year, the past year, of course, that were significant from a clinical standpoint. I'd like you to look at the first issue of the New England Journal of 2019 because he ranked the Reduce It trial as among the 3 most influential trials in 2018. The 3 most important trials published in the New England Journal of Medicine. Why is the trial very important? Well, the trial finally looked at the proper population where you could highlight the effect of lowering triglycerides. And what is the proper population? Well, patients with established heart disease at high risk for cardiovascular disease, diabetes, at least one other risk factors, but the key point is that these patients were properly controlled for LDL. I'll show you in a minute. The LDL at starting point was 73, which is at target at that time for the guidelines. And finally, the other great point is that they finally recruited people with the hypertriglyceridemia, not like in most of the fibrate trials where triglyceride level were in the range of 1.5, 1.7 millimole per deciliter, which is 150, 170. The triglyceride level is slightly above 200. A large number of people recruited, either omega-3, and it's a single component EPA, 4 grams a day. That's the other important point. Not 1, not 2, 3 to 4. That's the effective drug, the dose for triglyceride. 2 times a day, 2 grams. So 4 grams a day overall. Long follow-up, 5 years. A group, 4,000 omega-3 and high-intensity statin therapy, the other one on high-intensity statin therapy. Now, the starting point of LDL is 74. No major effect whatsoever, although there was some significant decrease as compared to the placebo group. But as you can see, really, that's not the effect of omega-3. Triglyceride levels, baseline after a year, decreased by 45 milligrams, about 20%. Non-HDL cholesterol decreased. But what I'd like to show you is the remarkable effect on cardiovascular events in a population already nicely treated for LDL cholesterol. This is a 25% reduction in the cardiovascular, the primary endpoint, coronary death, non-fatal MI, non-fatal stroke, revascularization, and stable angina. A number of patients needed to be treated of 21 overall, the population, with an absolute risk reduction of almost 5 and a relative risk reduction of absolutely of closing to 25%. On top, the placebo group of a very nice, I would say, up to what the guidelines at that time were suggesting, LDL cholesterol control. But what was striking is this figure. This figure tells you each one of the components of the primary endpoint and the secondary endpoint. And as you can see from the numbers, they were all reduced by 25 to 30%, each one of them. We're talking about fatal and non-fatal MI, urgent or emergent revascularization, cardiovascular death, hospitalization for angina, fatal and non-fatal stroke, and so forth. So this approach led to a remarkable further benefit in a population already well controlled for LDL cholesterol. Now, I don't have time to get into details, but if you read carefully the trial, definitely it's not only triglycerides. Of course, you get a nice decrease in triglyceride, nice decrease in HDL, but you get a slight, although significant, increase in bleeding, although it was not serious bleeding. And unlike the trial with simvastatin ezetimibe, which ezetimibe is added to any statin, in fact, or where PCSK9 inhibitors are added to a statin ezetimibe, you see a further decrease in the high-sensitivity CRP. That tells you that there is a further anti-inflammatory action of this drug as compared to the statin background. So the last 2 slides, just to give you a practical hint about superb control. The guy number 1 has an LDL problem. So the superb LDL control is mandatory in this guy, according to the new guidelines. We have a very effective, very inexpensive, cost-effective way of doing it. In certain cases, according to the actual cost per year of the PCSK9 inhibitor in Europe, I would say, or around the world, we have a further extremely effective way, but also more expensive. What we can expect in terms of event reduction as compared to a guy that starts with an LDL, let's say, around 100 or 80, another 40% to 18% relative risk reduction. In this kind of patients, we have an LDL and triglyceride phenotype. We may use exactly the same approach. That has been used time and again in our lipid clinic. Forget about the triglyceride. Triglyceride is not a problem. Let's go down to the LDL. And we may expect exactly the same point. These guys, on the other hand, even as compared to Mr. Green, Mr. Red has a remaining residual risk, which is higher. And is clinically relevant, even for extremely low levels. So what I like to suggest is that we have evidence that in this case we have a second path once the LDL is at least below 80 or 2.0 millimole, although not at target. But we do have the evidence of superb triglyceride control, and that's the other point. And the drugs or the pharmacological approaches are different. EPA, or omega-3, and fenofibrate, I haven't had time to show you, There are some data of subgroups, all the subgroups in fact with fibrates, and the actually decrease. Look at the numbers. So if you look at the numbers, I think we may argue whether it's worthwhile going way down here or maybe approach the patients here and maybe use a combination with an expensive combination and then shift the patients to something or associate something that lowers triglycerides. But these are the numbers with the triglyceride lower approach once the LDL is controlled, 25 to 30%. These are the number in the same patients when you go strong on LDL. Is it the end of the story? And this is going to be my last slide. So are we approaching the final battle against cardiovascular disease? The answer is unfortunately no. Superb control of lipids doesn't allow you to take that kind of conclusion, because I'd like to show you what superb control of lipids in Fourier leads according to increasing CRP levels. So it's almost doubling of the risk, and this is called superb control. It's half a millimole, less than 20, from 5.3 to 8.9. I can show you exactly the same figures for Lp(a), for other risk factors. So I think the idea is that in the context of the precision medicine, superb lipid control is definitely put us in a position to win a very relevant battle against cardiovascular disease. We can use a superb LDL control in certain situations when the LDL is the problem, not the triglycerides. But we have a second option that when LDL is nice, and by nice I mean lower than 80, or if you're able, even lower than 55, of course, considering the risk of these patients, we can use a superb triglyceride control that pays off as well. And of course, nothing prevents us from combining some of this drug and use a triple therapy. What I'm suggesting is that there are high CRP, high Lp(a), procoagulant states. We have, I think, Niklaus and all the cardiologists and diabetologists in the room have time and again evidence of patients that despite a very tight control of both lipids, triglycerides, and LDL cholesterol, nice glucose control, nice blood pressure control, they have a rapidly progressive cardiovascular disease, recurrent acute coronary syndrome, and we don't know what to look at. And I think instead of limiting ourselves to superb lipid control, in the future the situation is going to be more complex but more exciting from our standpoint, and probably we have to look for superb holistic control, looking at inflammations, coagulation, and other risk factors on top of the lipids. Thank you very much for your attention.
Thank you, Alberto. Great presentation, which is now open for the discussion. We have two hands raised. First, Riccardo, or anyway, Ele Ferranini. Great. Perfect.
Very nice, Alberto. Two snip questions, very quick. First of all, can one use ApoB for non-HDL cholesterol, since that's the common particle between the two? And second, against the enthusiasm of the editor of the New England Journal of Medicine, I believe I've seen a meta-analysis of omega-3 fatty acids showing no effect.
Yes, both very important questions, very well taken. Number one. Number two, actually, start with number two with the meta-analysis, because that has created a lot of confusions among the doctors. The meta-analysis is a mixed bag of patients with different cardiovascular risk, not high risk, mixed primary prevention. But what makes things worse, mixed doses of omega-3, 800 milligrams, 1 gram, has nothing to do with triglyceride. And in fact, EMA, the European Medicine Agency, issued a warning against the efficacy or effectiveness, I think Riccardo can correct me on that word, of the supplementations of omega-3 for prevention of cardiovascular disease at 1 gram a day to prevent what the GC trial showed us, post-MI sudden death within the next 9 to 12 months. Of course, the GC trial was performed with a very different background of therapy. Now we have a much more effective way to treat these patients. So probably supplementing 1 gram a day, not 3, 4, 1 gram a day is not leading to an extra or significant results anymore. So thank you for this question, because it allows me to make a point. Triglyceride lowering doses are very different from, and the ones used in reduced at 4 grams a day are very different than the dosage used in the meta-analysis, which you look at is 1.2 on average, but anywhere from 2 to 0.8 grams. So very different, careful about. First question was about the ApoB. ApoB is a great, it's the measurement. If you look at the triglyceride paper I showed you on the randomized trial, they look at ApoB. ApoB can tell us, and sorry I go back, but it's the other, in fact, parameter that is suggested by the guidelines. And I think I'm getting there. Okay, yeah. Look here. ApoB analysis is recommended for risk assessment, particularly in people with type 2 triglyceride levels, diabetes, as primary measurements instead of LDL. Because it tells you the number, the real number of particles, the atherogenic particles that are circulating, regardless whether they carry mostly triglyceride or mostly cholesterol. So it's the real number. We knew it since 20 years. The problem is not everybody measures ApoB. It's more, it costs you a little bit of extra money. Not much, but a little bit of extra money. Whereas the non-HDL, although it's not as nice, but it's a simple math. Total minus HDL cholesterol. So I agree with you. I think the final point, the final marker for appropriate treatment and cardiovascular risk at the end of, let's say, in the next 10 years, will end up being ApoB. Definitely, no question. That's the conclusion of the Brian Ferris meta-analysis. Said no matter whether you treat triglyceride or LDL cholesterol, you look at ApoB changes and you have a very good answer of how the patients respond to treatment. So yes, absolutely. Only not effective or not feasible in every lab or every hospital, particularly smaller hospitals.
Well, Alberto, thank you. Really super lecture. May I take again the point of the ApoB?
Yes.
Because I think that the biology tells us that that is really the important particle, the important apoprotein. Yet, to recommend it for risk assessment before therapy as an isolated parameter is going to be a little bit difficult, even if we have an optimal measurement of this parameter, because the experience, the amount of data available to assess the risk with that number is much, 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 much less than the amount of data we have with LDL cholesterol or non-HDL cholesterol. So I may agree with the idea that is an excellent parameter to show the effect as an intermediate phenotype of my intervention, but perhaps to use it by itself to paint the lipid-related risk, don't you think is a little bit overstretched?
I would put probably two. You said much less. I would
would
say much less, only too much.
Well, how many? Which threshold should we use? And how much 80, is standardized?
For example, for very high-risk patients, is 80 milligram per deciliter. If you look at, it's not here, it's in another table. I think, Riccardo, the idea is that with the ApoB you cover all the atherogenic lipoprotein. In patients with diabetes, you cover also the triglyceride, the rich lipoproteins, which are atherogenics on a one-to-one basis as compared to the LDL cholesterol. I agree there are fewer studies than the LDL as a predictor of cardiovascular disease, simply because it's harder to measure. But all the studies we have, and there are three particular relatively large studies, including the two studies with the PCSK9 inhibitors, has been consistently shown to be a better predictor of disease than LDL. It's going to take time. I think right now I've been pro ApoB since 20 years, but I agree it's difficult to promote. It's difficult to promote as a measurement for daily practice. Non-ApoB is something that is a surrogate right now, but it's inexpensive. It gives you an idea of all the atherogenic lipoprotein anyway. It's not as precise as ApoB, but better than LDL, particularly in patients with diabetes. And I was surprised to see NICE in 2014. They said, look, in patients with diabetes, you should probably look at non-HDL rather than LDL. And coming from the UK, it was quite striking, actually, because they said it's more cost-effective and it's more relevant for prevention of cardiovascular disease.
I'll put in discussion on HDL. One further question, then at the end. As far as I'm concerned, number needed to treat to benefit. The problem I have with what usual researchers do is that they do not report the number needed to treat to benefit per year.
Yeah.
All those numbers you have shown are actually on different year intervals. For instance, one may think that IMPROVE-IT was more efficacious than the PCSK9 inhibitor study in diabetes. It's not.
This is a 7-year number to treat, and this is
which means 100. If you multiply 18 by 7, it becomes 106, 110. which is in the same order of magnitude of the anti-diabetic drug I shown before. What I'm saying,
I know.
Well, but the audience, maybe part of the audience, especially my...
But look, I mean, this is 7 years.
Especially my students they are not more efficacious than anti-diabetes drugs.
No, I never said that.
No, but I'm saying
they are effective.
Since I've shown much higher numbers, I want just to make this point.
No, those are the numbers provided, but yes, of course.
Okay, Andrea Giaccari.
I would comment it's a superb talk, really elegant. I would like to you to clarify a little bit more on the difference between the reduced trial and the omega-3. I mean, it's true that the eicosapentaenoic acid is an omega-3, but it's just one. It's not generically omega-3. It's just like saying that since the EMPA-REG trial demonstrated that empagliflozin can reduce cardiovascular mortality, even sulfonylurea can reduce cardiovascular mortality, which is not true. I mean, it's just one and just that. Maybe some others, but it's completely different. It's not just a matter of dose.
No, it's a very well taken question. I think, and there will be one of the 3 out of 4 intervention trials that I mentioned had to do with triglycerides and will be published in the next 3 years, has to do with the combination DHA-EPA, which is the omega-3 formulation we have in Europe, because EPA is not marketed in Europe anywhere. So we have to wait the DHA-EPA another 2.5 years. The other one, by the way, is Pima fibrate, which is a modern version of fibrates without side effects, similar effects on triglyceride. Again, will be published in the next 2 years, 2.5 years again, particularly in this population with high triglyceride. Comparing EPA with DHA-EPA, I don't think we will have ever, never actually, the head-to-head comparison. Of course, those marketing EPA suggest that EPA used in REDUCE-IT has a peculiar effect both as an anti-inflammatory drug as well as triglyceride lowering. There's a statement, because that is a big issue, particularly in the US, where EPA is available. There is a statement published by the American College of Cardiology and the American Heart Association at the end of August, so a month and a half ago, suggesting with the data we have so far, we should consider combination EPA-DHA equally effective, although they don't have trials themselves, as EPA alone. Having said that, which is a statement by the American Heart Association, the data we have on EPA-DHA, the combination we have in Italy on triglycerides, are much more effective than EPA here alone. I like to remind you that it's only 20% reduction in triglyceride. With the 3 or 4 grams of the available combination, the triglyceride decrease in that population ranges usually between 40 and 50%. So if we believe that is triglyceride lowering related effect, not only but also related, I don't see any reason why the combination should be less effective. You remember the initial trial with statins. When rosuvastatin came out, they said, we should use it only in secondary prevention or only in primary prevention because we don't have trial in patients with heart disease, we don't have trial here, we don't have trial there. And then we ended up understanding it's a cholesterol lowering, no matter what. You can use a statin, you can use a fibrate, you can use ileal bypass, and the benefit depends on cholesterol lowering. My feeling is that the benefits depend particularly on triglyceride lowering, but not exclusively, because there is a triglyceride in there is a decrease in CRP in this population, and there is a significant increase in minor bleeding, which tells you that omega-3 at 4 grams a day also impact on the coagulation system, I would say aggregation and platelets activation. So it's a complex. Let's say it's one example of maybe a multifactorial approach with one drug, which is omega-3, affecting inflammation, triglyceride, and aggregation.
Marco Baroni.
Alberto, very brilliant presentation. I have 2 questions. One regarding fibrates, because I did not understand whether you think that this type of omega-3 are better than fibrates or similar. And in that case, probably they are cheaper, so maybe we should stick to the...
Fibrates are cheaper, much cheaper right now, yeah.
But are they equally effective on triglyceride lowering or not?
They are, depending on the population, but fibrates are usually slightly more effective than omega-3. The reason why I used to present a lot of data about fibrates, today I concentrate myself on the new piece of information. And I'm very much pro-fibrates. The only problem with fibrates, and I hope the new trial, Prominent with Pima fibrate, will fix that problem, is that particularly for the most recent trials, we have subgroup analysis in patients with high triglycerides, suggesting benefits. But the benefits we see in patients treated with fibrates monotherapy or fibrates simvastatin in accord, in patients that start with a phenotype like reduced, triglyceride above 200, low HDL, are in a range of 30%. So they tell us that probably it will be at least as effective as the omega-3. The reason why the guidelines, the most recent version of the guidelines, put the fibrates one step below is that they don't have the equivalent of the reduced in terms of strong data on primary endpoint. Not yet. I hope they will have with the Pima fibrate, because one of the downside of omega-3 4 grams a day is compliance. I mean, these guys are taking a bunch of pills, and you have to ask them to take 4 extra pills a day. I mean, in the long run, I think that is going to be hard. Whereas with the fibrate, you may even have a one-pill combination with the fibrate and statin together, like we already have with Fino or Simva, and in Europe, Fino Rosu or Fino Torva.
The second question goes back to ApoB. You clearly showed that there is a reason to get down the LDL level below 55. Why ApoB is still at 80? The cutoff.
Well, because as Riccardo said, I don't think we have that much evidence of. Remember that ApoB includes triglyceride and everything. So the number of ApoB remains higher because the ApoB, it's not only in the LDL, which may account for the 55 or lower, but it's in triglyceride. So it's in other lipoproteins. So overall, the numbers of ApoB, we do have less epidemiological numbers or data to establish a cutoff. But ApoB in milligrams is not equivalent to LDL or triglycerides. So it should not be 55. Is
I agree,
quite.
I was expecting to lower a little bit.
I think they don't have new evidence. That's the point that Riccardo was taking. We have new evidence for LDL. The evidence on ApoB from Fourier has not been published, and so I think they did not take into account that piece of information. Maybe in the future. I think it's just lack of data.
Okay, great. Thank you, Nicolas. Thank you, Riccardo. Thank you, Alberto. Great talk, great presentation, great discussion. Thank you, Enzo, for setting this up. And you have 15 minutes for the coffee, and then you have to rush back because there is a